webinar. And we have a very interesting and exciting topic this evening. The speakers today, Professor Zaida Qureshi, who is well known to most of us, has taught most of us in this audience. Karibu, Professor. Dr. George Guaco, consultant obstetrician, gynecologist, University of Nairobi. Dr. Alfred Osoti, Department of Obs and Gyne, lecturer. Then we have the panelists, Professor Anthony Wanyoro, Karibu Professor from KU. We have Dr. Alan Ecole, consultant obstetrician, gynecologist at KNH. And we also have Dr. Joan Okemo, consultant obstetrician, gynecologist from the Aga Khan University Hospital. Also among us should be Jennifer Okore, was part of this, and Polycarp Oyo were part of the EMOTIVE Trial. We are talking about the EMOTIVE Trial, and there's a publication which came out on 6th of June this year in the New England Journal of Medicine. New England Journal of Medicine started in 1812. That's almost 210 years ago. And we have the privilege of having colleagues among us who had this paper published. We're going to hear more about the EMOTIVE Trial, but in brief, this was about PPH. We all know that postpartum hemorrhage is a major killer, cause of maternal mortalities, together with eclampsia. There are various ways in which historically has been managed, but despite all the measures that we use, we find that we still have very high mortalities of mothers. Remember also for the young among us that when there is PPH, there are more and more innovations coming up, but we always must start from the basics, whereby we must recognize you cannot start treating something which you are not aware of. So this is part of it, getting to be aware and early detection, that is, of postpartum hemorrhage, so that after that, then we can institute the measures which you should be aware of about bimanual massage, uterotonics. The other time we had talked about carbetocin, which was also presented by the same group, incidentally, and we're very proud of you, Professor Qureshi, Dr. Soti, and Dr. Guaco, the B-Lynch, and balloon tamponade, and all those types. So without much ado, I'm going to hand over the next speaker, and we'll start with Professor Zaida Qureshi to probably start us off. And after the presentations, we'll welcome the panelists and questions to go along. Karibu, everybody, and karibu, Professor Zaida Qureshi.
Thank you very much. It's a privilege to be presenting this on behalf of our team. I was trying to switch on my video to show my face so that you all remember who I am, but for some reason I can't. So maybe at some stage it'll get enabled. So thank you very much for joining. Okay, fine, it has started. Thank you. So this is me. So let me just put on my video for the first few slides. As I said, it's a privilege for me to come in front of this massive number of participants who have joined. Thank you so much for joining us, for us to be able to share what we have this morning. So we know PPH is a problem. We even had a very nice webinar yesterday afternoon on postpartum hemorrhage. So in the spirit that the Kenya Obstetrics and Gynecology Society has earmarked September as the PPH Awareness Month, we felt it's an opportune time to share our findings also. So we are talking about advancing PPH management using the calibrated drapes and bundled approach of care with lessons learned from the EMOTIVE Trial. And basically, what are we talking about? We're talking about early detection and treatment and early treatment using the World Health Organization EMOTIVE, which is the first response bundle. And it's a cluster randomized trial that we are going to share the findings of. So as we've been introduced by Dr. Maranga, all of us are going to take turns in presenting some part of this presentation today. Am I going to be able to move my slides? Okay, so we are going to talk to you this evening. First, I'm going to take you through the overview of the EMOTIVE trial. And in this, I'll take you as to why we felt we needed to do this, how did we do this, and then what are our results. And myself, Dr. Guaco, Dr. Soti will take us through this. And then we'll come to the nitty-gritty of what we did in the facilities and how this was done and what are the challenges that we identified and how we met them. And this will be taken through by our implementation midwives. And then we will open it up to a panel discussion. Next slide. So let's look at why we felt we needed to do this trial. So I think we are all quite aware of the problem, but let's remind ourselves. So there are about 24 million women globally every year who end up having postpartum hemorrhage. And about 15 million of these are out after a vaginal birth, and about 9 million after a cesarean section. So the problem is there on both sides. Of course, vaginal deliveries are more than cesareans globally. But we know that if postpartum hemorrhage continues and we do not manage to control it and treat it, then women die. And they die in our hands as we are treating them, or we treated them to the best of our ability, but we did not do enough. So they ended up dying. And about 74,000 women die annually from postpartum hemorrhage-related complications. And this number is not getting better. It's going to get worse. It's going to reach about 81,000, not millions, I may have made a mistake, by the year 2030. So this is the reason we felt we have talked enough about postpartum hemorrhage. We've done a lot, but what more can we do? So this is what we did in this trial. So we wanted to try and do something more than what we've been doing. Next slide, please. So let's look closer to home. What are the issues with us? That was global data. We know that our current maternal mortality ratio is 362 per 100,000 live births. I was guided by our colleagues from the ministry that this is the official figure we should be using. And we know we have about 6,000 maternal deaths every year. And when we look at the data from the confidential inquiries into maternal deaths, the first report was 2017, but subsequently we have data for that first one was up to 2016, published in 2017, but 2017 and 18, we have more data. And overall, it's about 38 to 40% of the deaths that happen are due to obstetric hemorrhage, followed by hypertensive disease. Most of that obstetric hemorrhage is postpartum hemorrhage. So look at the magnitude of the problem we have in this country of postpartum hemorrhage. So in our institutions, the tertiary institutions, maybe it's hypertensive disease, which is taking the lead, but in the country, it is still obstetric hemorrhage, and most of that, as I said, is postpartum hemorrhage. Next slide, please. And we have the next, okay. So why does PPH continue to be a problem? And let's look at what happens in a facility level. We have challenges, and the first challenge is missed or delayed diagnosis of postpartum hemorrhage. Then we delay to treat it when we do not diagnose it, and then we treat it to some extent, but we do delay to escalate, and it eventually gets to refractory postpartum hemorrhage, and then we still are not able to control. So let's look at each challenge one by one. Next slide. So let's look at this as an exercise. We do this when we are doing our trainings. And how do we diagnose postpartum hemorrhage now? If you conducted a delivery today, what did you put the blood loss as? You just looked and you said, oh, I think this is 200. Oh, I think this is 300. And we call that, my implementation midwife calls it machometer. It's the machos that are looking, the eyes that are looking. So it is what we see and what we want it to be. So we have here some containers and we have some liquid with some dyes to mimic blood. We have some gauze. So let's try out this exercise. Of the one that you see on this table on the left side, look at number C. It's a kidney dish. It's a medium-sized kidney dish with some liquid to mimic blood. So tell us, how much do you think that blood loss looks like to you? With your eyes, visual estimation. And let's see what comes up in the chat box. So who's going to tell me what's appearing in the chat box? What are the responses coming up? So once we've had a few, we'll move on.
So we have a 350, 500, 250, 100.
Okay. Yes, I'm also able to see now. The final one was 500. Okay, great. So that's a nice variation. Yeah. Great. Okay. Now let's show you the response.
There's one liter as well. The
Okay.
highest I think is 1 liter.
Okay, great. So let's see the next slide. So it varied, right? So those of you who said it's 1 liter are going to treat it. Those of you who said something lower. Okay, let's have the next slide, please. It's a bit slow to move. Okay, here. So this is what happens in a training. We ask the participants to go around with the sticky notes and they look at each and then eventually they come and stick it. So let's look at what we have for C. We have anything ranging from, I think, 200 to 1000. But the correct response here was 300. So this was 300. So you see how inaccurate we are when we just look and come up with some figure. Okay, let's move on. So we've shown you that visual estimation is almost like a blind estimation. So what do we do if this visual estimation is so inaccurate? We have to come up with something that is accurate. And to further prove our point, we are sharing data with you from the Champion trial, which Dr. Maranga just spoke to us about. So this is the trial that we compared carbetocin to oxytocin to prove that heat-stable carbetocin was non-inferior. And if you look at the x-axis, if somebody who's controlling the cursor, see that when we had reached 500 mL of blood loss, only 26% of women who had 500 mL of blood loss, which is PPH, had actually received a treatment utrotonic, a utrotonic for treating the 500 mL. So it was only 26%. And then when you look at 1000, which is severe postpartum hemorrhage, 70% luckily had received, but 30%, a whole 30% still had not received treatment. And then when you look at that shaded area, which is the graph under the, above the curve, you see that almost 47% of women had not been diagnosed with PPH when they had PPH. So look at the number of women we are missing. So this is concrete data from a robust trial, which was conducted in 10 countries, 8 low and middle income countries, our included. So we have evidence that we do not do a good job in diagnosing postpartum hemorrhage. Next, please. So what do we do? And we further are able to prove that in our EMOTIVE trial, which we are going to share more information about, we had intervention sites and we had control sites. So in our control site, on the left, you see that again, 52% of the PPHs were being missed. So the 4 countries that participated were Nigeria, Kenya, Tanzania, and South Africa. We had a slight variation in the rates that were being missed in the country, but overall it was 52% that were not being picked. So this is a very worrying situation. Next, please. So what do? We do not do a good job of estimating by just visual inspection. So we need to have something that will give us a better estimation. So an objective measurement of blood loss. So we can use some sort of a non-calibrated blood collector, something like a bedpan we put under the buttocks of the woman. It's going to be uncomfortable. We can have what we've shown in the middle, the Cali's pad with some basins. The blood, trickles down into a receptacle at the bottom. We can have some standardized cloth mats that we know if it's completely soaked, it's going to have so much blood, etc. But what you see on the right side is a calibrated drape. It's a plastic apparatus. It's put under the buttocks of the woman. It has some bands that can be tied over her, and it has a cone-shaped receptacle at the bottom, and all the blood trickles into this pouch. And we have some markings so we can see how much it is. For research purposes, we actually, at the end of the 1 hour of blood collection, remove it and put it on a scale and weigh it, and all that is going to be explained a little more today. That is routinely used in some countries, in many parts of India, and I think more in Vietnam. So we recognize that we have missed or delayed diagnosis. What is the next challenge? We delay our treatment of PPH. Next slide, please. So when we delay, of course, that is causing a consequence for our patients, because you take a long time to recognize there is blood loss. So you're going to delay your initiating your treatment, and then it's going to be delayed as to how effective it's going to be. Next slide, please. Sorry, it's taking a bit of okay, here we have it. So what is the usual care that we are providing? We have, as soon as we do recognize there is postpartum hemorrhage, we say, okay, let's call in our team, let's massage the uterus, and we massage it for some time. Hopefully it will control the postpartum hemorrhage. We may think of doing something else in the meantime. We look for our oxytocin drugs. Maybe after 10 minutes, we start administering one. It may work, it may not work. In the meantime, we start looking for tranexamic acid, which might not even be in our labor ward. We have to go look for it somewhere. We start giving that, and then we continue escalating. We look for another uterotonic, and overall you can see it goes from 5 to 10 to 15, maybe 20, 30, 40 minutes. And we've spent that much time trying to do one intervention after another. So the usual care of sequential treatment takes time. So WHO in the meantime had published data on, had a publication in which they spoke about the EMOTIVE bundle. And a bundle is putting in an intervention with many things in it, many components all at once. So the EMOTIVE stands for M, starting from massaging the uterus, O for oxytocin drugs, T for tranexamic acid, IV for IV fluids, and then you escalate for examining and treating with confirming that there is no other cause of that bleeding. So this is then put in as a bundle very quickly, and we're going to hear a lot more about how this bundle is implemented. So then we have missed or delayed escalation. So finally, we've done that bundle. If we are using the bundle, and if we were doing the routine, sequential treatment, we then still were not doing things very fast. So if we put in our EMOTIVE bundle and we still continue to have bleeding, then we need to put in the escalation criteria, which is if you have brisk uncontrolled bleeding, if you have blood loss more than 1 liter in the calibrated drape, you have hypotension or collapse, or you have extensive genital tract trauma, including a 3rd-degree tear. So you must escalate. You must examine, you must find out what's happening and move on. And the moving on might be something you do in labor ward, something you have to do when you take the patient to theater. So do not just look at the blood loss and do nothing. You have to escalate by examining the genital tract and escalating to the next level. Next slide, please. So do not delay the escalation. So that was our third challenge. So what are we doing here? So let's move quickly. Current practice is we diagnose. It takes a long time. We put in our first response treatment sequentially. So it's taking 5, 10, almost 30, 40 minutes. Then we feel we need to escalate. So we take a long time escalating. And then we finally do the refractory treatment. So against that, look at the EMOTIVE bundle at the bottom. So we say we do early and accurate diagnosis by putting in a drape. We implement the bundled treatment, which is the EMOTIVE E. The first E is for early and accurate diagnosis. Then we put in the motive, and then we escalate, which is treatment for refractive. So can you look at the difference in time on the top and the bottom? We've reduced it immensely. And that is what is going to save women going forward. Next slide, please. So I have spoken to you about the need for doing this trial. We have inaccurate diagnosis. When we diagnose, we still take very long to work on it, and we still take longer to escalate. So I'm now going to hand over to Dr. Gwaku to take us through what we did in this trial. So he's going to take you through the how. Dr. Gwaku.
Thank you, Prof. Qureshi. So we've heard of the why we did the study. For the next few minutes, I'll take you through how we conducted the EMOTIVE study. So in terms of the study design, this was a multi-country, multi-site, cluster randomized trial. It had we had 3 phases in the trial. We had the formative phase, a transition phase of 2 months, and the trial phase that lasted 7 months. Now, during the formative phase, many activities happened, but we had 4 key ones. The first one is that we had several design workshops. Some of them were in person, some of them were virtually. Number 2, we had a mixed methods formative work. Over here, we're interested in the key outcomes in the EMOTIVE trial. We wanted to understand how postpartum hemorrhage is diagnosed and managed in the 80 sites that participated, and what are some of the factors that influence the diagnosis and management of postpartum hemorrhage. There's actually a paper on this that we'll be able to share. The third main activity among the many that we did during the formative phase was that we did not want the study to fail because of quality issues. So we conducted a survey on the quality of tranexamic acid and oxytocin that was available in the 80 sites that were participating in this trial. Without going into a lot of details, what we found was actually shocking, that a good proportion of the oxytocin that was available in the sites was of poor quality. Tranexamic acid, not so bad, but quite a good proportion of the tranexamic acid that was available so was not of good quality. Again, there's a paper to this effect that was published sometime last year. We'll be able to share. The fourth main activity during the formative phase was what we call the adaptive cycle or a pilot. We did a piloting of the intervention where we introduced the EMOTIVE bundle to 3 sites per county, just to understand how it was going to work and to troubleshoot before we went to the intervention phase. So the whole of this formative phase took about 7 months. In the transition phase, before we went to the intervention phase, this is where now we were planning what we're going to do in the intervention, doing trainings, procurement of the equipment that we needed, etc., etc. In the intervention phase, 40 of the 80 facilities that participated were randomized to the usual care, that were our control sites, and 40 were randomized into the intervention arm, where postpartum hemorrhage was going to be managed using the EMOTIVE bundle. Sorry, there's a bit of a lag. So this is the paper I was talking about that looked at the quality of oxytocin and tranexamic acid in Kenya, Nigeria, South Africa, and Tanzania. It's actually available, and you can download and watch it and read it. These were the adaptive cycle sites in Kenya. There were 3 of them: St. Mary's, Karatina, and Makueni. In terms of the methods, our study population were all women giving vaginal birth at the study sites. We did not include women who had cesarean deliveries. The intervention, as Prof. Kresha had already mentioned, was the early detection of postpartum hemorrhage and the treatment bundle, which consisted of uterine massage, oxytocin drugs, tranexamic acid, administration of IV fluids, examination, and escalation. We'll unpack this as we go along. The comparator or the control was usual care, but we ensured that we disseminated all the current guidelines on the diagnosis and treatment of postpartum hemorrhage. And when we present the results, you'll notice that even in the control sites, actually some of the sites were already using EMOTIVE, either the whole MOTIVE bundle or a few components of the EMOTIVE bundle. We had many outcomes that we are looking at, but the primary outcome was a composite of severe postpartum hemorrhage that was defined as a blood loss of more than 1,000 mL, or postpartum laparotomy for bleeding, or postpartum maternal death due to postpartum hemorrhage. We had several secondary outcomes that I'll talk about as we move along. As I said, this was a multi-country, multi-site randomized clinical trial. We had initially 5 countries, that's Nigeria, Kenya, Tanzania, South Africa, and Pakistan. Pakistan had challenges with flooding, so they were not able, by the time they were ready to start, the other 4 countries had almost done with the study, and this did not affect our power or the sample size. So in Kenya, we had 14 sites. Initially, we had 16, we dropped 2. Nigeria had 38 sites, Tanzania 14, South Africa 14. The unit of randomization was the cluster, and the unit of analysis were the women were giving birth in the study facilities. Now, for a hospital to qualify as a cluster in this study, there was a criteria. Number 1, they had to be middle-level hospitals having about between 1,000 and 5,000 deliveries in a year. Number 2, they had to be able to provide comprehensive obstetric care and also have the ability to perform surgery for PPH. Remember that surgery for PPH was one of the 3 components of the primary outcome. So we did not want a situation whereby somebody developed postpartum hemorrhage and then she's referred to another facility for care. These were the Kenyan sites. As I said, we started with 16, but we dropped 2. So we had 7 sites in the intervention arm and 7 sites in the control arm, as shown. I'm actually happy to note that all our OBGYNs that participated in this study are in the call, and we are grateful for that. What does the bundle entail, or what was the intervention? As I said earlier, the intervention was the EMOTIVE bundle. The first E, as Professor Kresha has already said, was the early detection of postpartum hemorrhage. The MOTIVE, as Prof has said, is actually something that is not new. This is a bundle that was introduced by the World Health Organization in 2019. But until the EMOTIVE trial was conducted, we did not know whether it is superior, inferior, or as good as the routine care. So the M stands for massage of the uterus. I'll talk about it a bit. O stood for oxytocin drugs. T was tranexamic acid. IV was IV fluids. The last E was examination and escalation. So let's look at the components, each of these components of the EMOTIVE bundle. So for early detection, this was actually the key innovation in this study. We used calibrated blood collection drape that had markings from 0 to 1600. But then key to this is that it had a warning line when the blood loss hit 300. It had an action line when the blood loss hit 500. So what happened is that when a lady went into second stage, the drape was put below her buttocks. Once a baby was delivered, then it was unwrapped, and we collected all the blood that the mother lost for 1 hour or for 2 hours for those who continued bleeding beyond 1 hour. We also observed blood loss, blood flow, uterine tone every 15 minutes, and this was documented in the blood monitoring chart. We monitored the mother's vital signs, that's blood pressure and pulse rate, for the first 1 hour. The reason why we used the drape was, number one, so that we have an objective measurement of the blood loss, and also to advise us on when to trigger the EMOTIVE bundle. So we had a trigger criteria. When did we trigger the other components of the EMOTIVE? So we triggered the other components based on 3 trigger criteria. Number one was the clinical judgment, and this is what we ordinarily do. So if we have a mother who was delivered and maybe the rate of blood flow, in as much as you've not hit 500 or 1,000, you feel that this mother is actually bleeding a lot, they were allowed to trigger the other components of the bundle. Number two, if the blood loss hit the 500 ml mark, the bundle had to be triggered. Number three, or if the blood loss hit 300 ml or more, and the mother had 1 abnormal observation. By 1 abnormal observation over here, what you're talking about is either a tachycardia or an hypotension. So the second component was the uterine massage. We massaged the uterus until we got a contraction, or for 1 minute. The reason we didn't want to go beyond 1 minute is because all the interventions had to be given within 15 minutes, and we did not want to spend a lot of time doing the massage and compromise on the other components of the EMOTIVE bundle. O stood for oxytocin drugs. You realize that in the routine management, there are various dosages of or ways of how you can administer oxytocin. So for this trial, we gave oxytocin as 10 international units in 500 ml of normal saline, and it was given as an infusion over 10 minutes, followed by 20 international units of oxytocin in 1 liter of normal saline, and this was given over 4 hours. So for those sites that combine oxytocin and misoprostol, this was still done, and misoprostol was given at a dosage of 800 micrograms, either per rectal or sublingual. The T, I'd already said, it was tranexamic acid for this study. It was given as 1 gram IV into either as a slow bolus for 10 minutes or diluted in 200 ml of normal saline and given as a slow infusion over 10 minutes. The IV was IV fluids, and in addition to the infusion that we had already started, the 500 and 1,000, we gave additional IV fluids if they were indicated for resuscitation. The last E stood for examination and escalation. So this is where the other T's come in. So we ensured that the bladder was empty. We evacuated clots. We checked for any perineal, vaginal, or cervical tears. We checked the placenta for completeness. If we had given the entire bundle and the patient continued to bleed, or we were unable to identify or manage the cause of the bleeding, then we had to escalate. So the last E had examination and escalation. So escalation over here was either to call in a senior medical officer or a consultant, taking in the patient for repair of the perineal cervical tears, doing a billing, taking the patient to theater for an EUA, and all that, although those were not part of the EMOTIVE bundle. So the last E, examination and escalation. Remember, one of the challenges that Professor mentioned was late escalation of patients who have postpartum hemorrhage. So this EMOTIVE bundle was also coupled with an implementation strategy. The implementation strategy had 4 main components. I'll mention them in passing. We'll have my colleagues will come in and explain in details the details of the implementation strategy. So the first component of the implementation strategy was training. The second one was the use of trolleys or carry cases. The third was use of champions. The fourth one was use of audit newsletters. In summary, the trainings were done on site as opposed to currently where you take people to hotels for 1 week. It was simulation-based, peer-assisted. It lasted anything from 90 minutes to a whole day. The trolley and carry cases, these ones were used to ensure that all the medicines and devices that were required for the treatment of postpartum hemorrhage were available within reach. And anytime a component was used, we had to ensure that it was restocked at the start of every shift. So we ensured that if you needed, for example, a branular, it was available within reach. You needed spirit soaps, they were within reach. If you needed a giving set, it was available. The drugs were available within the trolley or the carry case. The only thing that was not available in the trolley or carry case was oxytocin because of issues of refrigeration. We had 2 champions, 1 midwife, 1 doctor, whose main role was to oversee change, troubleshoot, and give feedback on the audit newsletters, which were the 4th component of the implementation strategy. So for the audit newsletters, what happened is that for the data that was collected during the previous month was shared with all the sites. We shared information about the total number of deliveries, how we did in terms of detecting postpartum hemorrhage, how we did in terms of detecting severe postpartum hemorrhage, and how we did in terms of administering the key components of the bundle, that is oxytocin and tranexamic acid. We also gave feedback on blood transfusion, laparotomy, and mortalities. This was to enable each site to interrogate their data and improve on the gaps that were found during the prior month. The comparator or the control, as I said earlier, was the usual care, but we ensured that the sites had the current guidelines on detection and postpartum hemorrhage. The other thing I could mention is that for the control sites, they also collected blood after delivery for 1 hour, all 2 hours for those who played more than 1 hour, but their drapes were not calibrated. So they continued with the usual care as it currently entails. Our outcomes, as I mentioned, we had quite a number, but the primary outcome was a combination of 3 clinical outcomes: severe postpartum hemorrhage, which was defined as a blood loss of more than 1,000 mL, postpartum laparotomy for bleeding, or postpartum maternal death from bleeding. This study was powered to detect a 25% reduction in this composite outcome. That is from the baseline of 4% to 3%. The key secondary outcome was PPH detection, compliance with the EMOTIVE PPH treatment approach. We had other several secondary outcomes, most of which were components of the primary outcome. So we collected data on blood loss of more than 500, blood loss of more than 1,000, laparotomy for bleeding, maternal mortality due to bleeding, all-cause maternal mortality, blood transfusion for bleeding, use of IUBT, admission to ICU, or referral to a higher level hospital, among other secondary outcomes. So the results we're going to present, we are very sure that they are valid results because we did source data verification for all the information that was collected. For example, for the blood loss, so after 1 hour, the drape was removed, it was folded, then it was measured in kilograms, later transformed into liters. So for any data that was collected on blood loss is something that can be verified, as shown on that photo. In terms of recruitment, as of now, the EMOTIVE trial is actually the biggest trial on postpartum hemorrhage. We recruited a total of 210 participants in the 4 countries. Kenya contributed about 20% of the study participants, roughly 49%. The rest of the countries contributed the figures as shown on this slide. Nigeria contributing the most. This is the distribution of how we got the 49,000 participants from Kenya. In terms of case completeness, we had data for 99% of all the vaginal births that occurred in the 80 sites. We had pregnancy outcome data for 98% of the participants, and we had 100% discharge outcome data. At this point in time, I want to invite my brother and friend, Dr. Osoti, to tell us about what we found. Dr. Osoti.
Thank you very much, Dr. Gwako and Professor Qureshi, and I'm grateful for this opportunity to present our study results on what we found. Now, I'll pause my video because of internet connection. So in terms of results, one of the things we look at carefully is whether there was balance between the 2 groups, that is the EMOTIVE group versus the usual care. Because if there is imbalance between the 2 groups, then it's possible to say balance is what contributed. But as you characteristics comparing EMOTIVE and usual care, generally these characteristics were comparable. The baseline characteristics were comparable between the 2 groups. For example, the number of vaginal births per hospital, the median was about 1,100 or 1,200 there, which was not that different between the 2 groups. Availability of the bundle components, for example, was 100% in either group. For the women that we enrolled in, again, comparable. In looking at the characteristics, we also looked at the risk factors for PPH. For example, multiparity, as you can see, it was comparable. 5 or greater was 9.2% in the EMOTIVE versus 9.9%. PPH in previous pregnancy, for example, was 1% across the groups, between the two groups. Multiple births or multiple pregnancies associated with PPH, for example, and again, that was comparable between the two groups. So we can confidently say that looking at the risk factors for PPH and looking at other baseline characteristics, they were comparable between the two groups. So the outcome that we are seeing is due to the intervention. Next slide, please. So our primary outcome, as my colleagues have mentioned, was composite. So it was a composite of severe PPH, which was blood loss of 1,000 mils or more. And of course, when patients bleed and we are not able to control the bleeding, end up with laparotomy for bleeding. So that was the second component of that primary outcome. And of course, if after laparotomy or before laparotomy, for whatever reason, we lose the mother from bleeding, then we have maternal mortality from bleeding. And that was the third component of that primary outcome. So we looked at the primary outcome in the usual care arm, which was high at 4.3%, close to 4% that we had estimated. And in the EMOTIVE arm, it was 1.6. So this, colleagues, was a 60% reduction, okay, in the primary outcome comparing EMOTIVE and usual care. If you remember from the power and summation that we had, we were estimating that there would be a difference of 25%, but we ended up with a 60% reduction, more than what we anticipated. Now, for those who want to delve more in the statistics, as you can see, the risk ratio was 0.4, and this 0.4 was less than the null value, which is 1. So there was a reduction, and it did not include the null value. And as you can see from the p-value, it was statistically significant. So this was not only clinically significant, but also statistically significant. So one of the take-home messages here is that using EMOTIVE intervention, you reduce the risk of severe PPH, laparotomy for bleeding, and maternal mortality from bleeding by 60%. Next slide. So we also had a series of secondary outcomes, that is PPH, blood loss of 500 mils or more, severe PPH, which was 1,000 mils or more lost, then maternal mortality from bleeding, all-cause mortality, blood transfusion in obstetrics can be due to many things, for example, antenatally due to anemia, but we also looked for a blood transfusion for bleeding. So in most cases, this would be due to PPH, and then blood loss up to 2 hours postpartum as a continuous variable. I want us to look at the column on risk ratio. As you can see, all these risk ratios were less than 1. That means there was reduction in PPH more than 500 mils. There was a reduction in severe PPH, reduction in maternal mortality, all-cause mortality, blood transfusion for bleeding, okay? But even though some of them were not statistically significant, the ones that I want to emphasize are PPH more than 500 mils was statistically significantly reduced by about 49%, severe PPH by about 61%, maternal mortality, all-cause mortality and blood transfusion was just about 20%. It was not statistically significant, but a reduction, and that is because of the small numbers that we had. And then blood transfusion for bleeding was statistically significant at 29% reduction. So again, the intervention resulted in reducing the risk of these adverse outcomes. Blood loss, again, the median blood loss was lower in the EMOTIVE arm compared to the usual care arm. Next slide. So we also observed the trend over time from the time we started the study at baseline. When we randomized, there was a transition phase that my colleague had mentioned earlier, and then post-randomization phase. Now, looking at the red line, which is the usual care arm, hovering around 4%. So there was not that marked reduction in that he was using the standard of care as it is currently. Now, if you look at the green one, which is the EMOTIVE arm, you realize that initially, as we were conducting the trainings, giving feedback, monitoring, and all that, it was essentially similar. But during the transition phase, we see a significant difference between the two graphs and a significant reduction in the EMOTIVE arm. So what this tells us is that the intervention worked and the intervention was sustainable over time. As you can see, it progressively decreased okay, compared to when we started at about 4%, while in the usual care arm, it remained around 4%. So such was possible in next slide. So there were other key implementation outcomes, which were PPH detection and bundle compliance. Because as you remember, one of the key interventions in EMOTIVE was ability to accurately detect. So when we compared the postpartum hemorrhage detection in the usual care versus the EMOTIVE arm, as you can see, in the usual care, we're detecting about almost half of the PPH cases. So we are still doing something, but at least 50%. Okay, but in the EMOTIVE arm, it was 93% because of other reasons. But look at that difference. So from half of the cases, 93% of the cases, and the risk ratio showed also statistical significance, meaning that in the EMOTIVE intervention, we were able to detect PPH. We were as likely to detect PPH 1.58 times compared to the usual care. When we looked at the compliance with the EMOTIVE bundle, okay, how did we perform? In the usual care arm, it was about 19%, while in the EMOTIVE, about 10%. So the risk ratio 4 times as likely, okay, to have compliance in the EMOTIVE arm, the usual care. Again, showing that these key implementation yeah. Next slide. Next slide, Jay. So I want now to hand you over to the implementation team to share how the implementation was and the challenges that were identified.
Thank you so much, Dr. Guaco and Osoti. It's a pleasure to take us through the next phase of this slides. So I'll unpackage the implementation strategy that we used. I'm Polika Poyo, I'm a midwife. Next. Next slide, please. Yes, so within the implementation strategy, we had 4 major strategies that we had employed for the purposes of managing PPH. And one of them, as the images show, we had the use of trolley and or carry case. I'll explain that later. We also had trainings. We had EMOTIVE champions, and also we had employed the use of audit and feedback sessions for the purposes of tracking our data and making decisions. Next. So the first strategy that I want to talk about is the trolley or carry case. So within this strategy that we used during the implementation, we conducted a needs assessment at every facility that we, at the intervention facilities that we were currently, or we were supporting then. And part of the things that we were looking at for us, for a facility to qualify for either a trolley or a carry case was the size of their maternity or labor ward, because there's facilities that will not have the capacity to or the space to have the trolley within the unit, and there are those that either were so squeezed, so we opted to give them the carry case. However, all the components that were in the trolley fitted well within the carry case. On this other end, as you can see, we had a checklist. So this checklist was used for both the trolley or carry case, and it showed, it guided the healthcare providers or the midwives on what should be inside the carry case or the trolley for the purposes of managing the PPH. And it was to be ticked on a daily basis. That means it was to be handed over like the normal routine, so that all that has been used for managing PPH would be then replenished back either in the trolley or the carry case. So these were for emergency PPH management. Next. Other than having the trolley or the carry case, we also had several trainings that we were able to do during the period of the implementation period. And part of the training, we began with TOT training, where we had select members from the different facilities coming over to be trained as TOTs. Then the TOTs will cascade at the facilities where they will plan and organize for on-site sessions, training sessions. And those who will have been trained during the on-site sessions will be qualified and certified as practice coordinators. So the role of these practice coordinators will be to conduct sessions that we were calling practice sessions. So these practice sessions were more of both knowledge and skills. And we also had the use of drills within the sessions. We had about 5 practice sessions. And we employed the use of this strategy known as the low dose, high frequency strategy. So at least a session per week for the 5 sessions, so that will lead to high retention of the skills and the knowledge to those that are being to the healthcare providers who were participating in those trainings. Other than that, after the trainings, then we will qualify these persons to be champions. So they will be championing, advocating at the facility level for the better management, that is early detection of PPH and the use of the bundle during the treatment of PPH. Next. So another thing that we were emphasizing on during the implementation phase was that the bundle, like the other speakers have alluded to, would be given within 15 minutes. And like we say, the EMOTIVE bundle that you're talking about comprises of the early detection using the calibrated drape, the massaging the uterus, oxytocin drug, giving oxytocin drugs, TXA and IV infusion, and you examine or you escalate when bleeding still persists beyond that. Next slide. So I'll talk a bit about early detection of PPH. So what do we currently do now, or what is the practice? Like we've seen in the previous presentations, a lot of healthcare providers still use visual estimation of blood loss. We also have observations being recorded in case records, and that is after the woman has delivered, that is postpartum. And the third thing that probably happens in our facilities is we have clinical judgment to diagnose PPH. So especially when the visual estimation of blood loss is misleading, many people opt to use clinical judgment. However, what is now new that we are advocating for, number one, is that we have calibrated drape as shown, and as we've been able to, we've heard from the previous slides, that is used to collect and assess the blood loss. And like we said, it has got 2 lines, which are color-coded, the yellow line and the red line. So the first line, like just as a reminder, is at 300 mils, and that should enable us to trigger the EMOTIVE bundle when we have 300 or 1 or more warning signs. And then the action line, that is at 500 mils of blood loss. So we're also talking about observations being recorded in blood loss monitoring chart, which I will also share in the next slides, every 15 minutes. And what we are emphasizing is when the pulse, and we only do it when pulse and BP is normal. So when do we trigger the EMOTIVE bundle? So we have the 3 criteria. Number one, we have clinical judgment of the healthcare provider to diagnose the PPH. The second criteria is when we have a blood loss of above above 500 mils on the drape. or we have a blood loss of 300 mils plus any abnormal observation. So these abnormal observations that we are talking about can be either when we have maybe we have heavy flow, we have large clots of blood, when the uterine tone is still soft, even after intervention, when the pulse rate and the PP rates are abnormal. So close to the image next, that is the blood loss monitoring chart that we had advocated for to be use management for PPH. And I can say that most of the sites that we were supporting during the implementation period actually adopted this as one of the tools within the maternity files. Why? Because they saw the use and the need that it had, or the importance that it had, especially to detect and managing PPH. So this document, as you can see, it is color-coded, and we were actually completing it within 1 hour or a duration of 1 hour after birth. And within that, we were calculating the cumulative blood loss after every 15 minutes until we see a resolution of the same. So within the other component of this blood loss monitoring chart is that it guides the healthcare providers on when and how to trigger the EMOTIVE bundle. So you may have a cumulative blood loss of 300 mils, but other parameters, as highlighted, are normal. So basically, you will not be able to trigger at that level. Next slide. So how do we provide this EMOTIVE bundle? The first thing is that all the interventions in the bundle should be given or will be given in the shortest time possible. And the time that we are having is 15 minutes. So you ensure that within 15 minutes, you've given all the components of the EMOTIVE bundle. And number two is that you give all the bundle intervention regardless of any improvement after any of the interventions. So we are coming out of the sequential type of managing PPH, where you give one component of the bundle, you massage the uterus, and you see the blood maybe stops to bleed, then you don't move to the other components. So that is what we are saying by giving all, and it is actually in caps, giving all the bundle interventions. The other one, if you are alone in limited resource settings, you will have to do all the interventions by yourself as quickly as possible. And through the trial, we noticed or we realized that it is possible to give all the interventions when you are alone in a facility, or if you have access to any help, you can assign a staff for each of the intervention, and you make sure that all the EMOTIVE bundle components or the interventions have been given or have been done. Next slide, please. So now in the M, where we talk about the massage of the uterus, what do we do now? Massaging the uterus is not well defined, and practice is variable. From the trainings that we conducted, both at the TOT and the on-site levels, we had various people coming out and demonstrating in a different fashion and different method how they massage the uterus, from the midwives to the healthcare providers at the labor unit. So what is new? Massaging you must massage the uterus until contracted, and if after 1 minute the uterus remains soft, you quickly move to giving a uterotonic. And that is why we insisted that we massage the uterus for 1 minute, and if it remains soft, you move on to the next motive bundle so that you don't delay in time. If contracted, you must check the tone every 15 minutes as you give the other components of the bundle. So what are the key points that we need to remember during the massage? You can go back kindly. The previous slide. Yes, thank you. So like I've said, we must provide other interventions. Uterine massage may hurt, and therefore you must tell the woman why you are doing it. You must explain to them. And also, we emphasize that you also need to teach the woman how to check the uterus, and if possible, support in massaging. You involve her in that process. And also teach her also to call the provider if the uterus is still soft, or they feel their bleeding has increased, or they are not feeling well. That is part of respectful maternal care. Next slide. In giving oxytocin drugs, what do we do now? Number one, oxytocin is given between 10 to 40 IU in 500 to 1,000 mils of a crystalline, specifically normal saline, over a few minutes or hours. The most interesting bit is that the maintenance bit or the dose is not always given in many instances. Misoprostol 600 to 1,000 microgram. It's often given because of either the restrictions that are there or the unavailability of it. So what is new? What is new is that we are advocating for oxytocin 10 IU to be given in 500 mils over 10 minutes. So that means the first dose should be given very rapidly. The maintenance dose, 20 IU in 1,000 mils, should be given over 4 hours for maintenance. And those are practices that have been proved to be good. Misoprostol 800 micrograms, either parectal or sublingual, can be given at the same time. Next slide. On the T, where we talk about tranexamic acid, we are to give tranexamic acid, that is TXA, as it is widely known, 1 gram IV. So what is the current practice, or what do we do now in most facilities? Tranexamic acid is not given, or given if oxytocin or misoprostol fail to stop the bleeding. And that is what we were talking about, sequential kind of management. And doctor's prescription is often required before administered. And I think that happens in several facilities. So what is new? Tranexamic acid, 1 gram IV, given over 10 minutes, should be given over 10 minutes for all women with PPH, irrespective of the cause at the same time with oxytocin. However, we are saying that we should use different IV cannulas or IV lines for the same. Clinical protocols signed in all hospitals should be signed in all hospitals to allow midwives to administer TXA without a doctor's prescription for the management of PPH. Like I said, in most facilities, we still need a doctor's prescription to get this drug. Next slide. Now we are at the IV, where we are supposed to start an IV infusion. So what happens? IV fluid administration varies widely for the management of PPH. So what is new? 500 mils of crystalloid, like I said, we're using normal saline, is given together with oxytocin over 10 minutes to all women with PPH. That is the first dose. And then further 1 liter of crystalloid is given with the 20 IU of oxytocin for maintenance over 4 hours. So maintenance dose should run for at least 4 hours. Additional crystalloid to be given only if required for fluid resuscitation, and may require another cannula for the same. Next slide. In the part of examine, where we are to check the bladder, the perineum, and the placenta, what actually happens now? Examination is very variable, and sometimes it's only visual inspection, with more detailed examination taking place if bleeding does not stop. Through the training that we we were providing, we had actually a session on how to examine the perineum and how to check that the bladder is empty. And because we saw this as a gap, a lot of people do not do a thorough examination of the perineum. They only do visual inspection. We only do a thorough examination when the bleeding continues. So what is new? We emphasize that you check and empty the bladder for all women with PPH. And now, yes, thank you. For all women with PPH. And like I said, one will ask, once the drape is already open, how do we ensure that this urine, especially for the women whose bladder is still full, does not drain into the drape, and that may interfere with our readings. So you may insert a Foley's catheter and drain it in a urine bag, but we are emphasizing that before every delivery, at least the healthcare provider or the midwife should ensure that the woman empties the bladder. The second thing is that we evacuate clots and check for tears with an internal examination for all women. So we advocate that thorough inspection and examination for all women with PPH. And number three, this is a challenge for most healthcare providers. We must check the placenta for completeness for all the women with PPH and to ensure that all the lobes of the placenta are present. Many times we don't check for the placenta. We don't examine the placenta. In terms of escalating, which after examining and doing all or giving all the bundle, the bleeding still continues, we need to seek further care when, number one, the mother still bleeds and causes have been identified and managed. Number two, you need to seek further care when the mother is still bleeding and causes are clear but unable to manage. The third criteria on escalating is the mother is still bleeding and the cause or the causes are still unclear. And that is basically highlighted in the action plan or the chart next there. In terms of communication, effective communication is extremely important in emergencies such as PPH. We need to communicate clearly and respectfully. Number two, we need to employ the use of ESPA, which is you communicate through the situation, background assessment, recommendation techniques. Remember that poor communication puts your patient at risk. Next. We are in the process of completing the implementation strategy, talking about the champions. So we had two champions who were selected by the health facility leadership. One was a doctor and one was a midwife who had ample clinical experience and were working in a clinical capacity within the facility's labor ward. So I'll rush through their roles. One of the roles was that they were to be present in the labor ward across different shifts, including weekends. So they had to be hands-on. They were to be drivers of change in the facility to reduce the burden of PPH and improve the outcomes. And then they were to become an EMOTIVE trainer by attending the TOT course and support the use of the implementation strategies, use of the calibrated or obstetric drapes and clinical observations, the EMOTIVE training rollout, use of the PPH trolley, and the others that I've talked about, the audit and feedback process. They also to coordinate and run the on-site training and practice activities for all the relevant staffs at the facility. Next. So we had the audit and feedback session. So these were posters that we were sharing with all the facilities from their data. That means that the data generated at the facility level using the tools that are available, the MOH tools at the facility level. So this poster basically highlighted their performance or the performance of each facility in terms of managing PPH And because of this, this tool was also used during the quality improvement sessions and the QI teams so that they are able to improve on their performance. So basically, the tool showed the number of vaginal births they had during the period, and that was every month, how many PPH out of the vaginal birth they had, how many severe PPH, how many were treated with a bundle as required. And also we had recommendations that were given to the facilities. Also, the tool had the total number of blood transfusions that were given because of excessive bleeding, laparotomy, or even deaths. So it's a tool that we that supported a lot to share back feedback to the facilities. So I'll invite Professor Qureshi to proceed from this. Thank you.
Thank you very much, Polycap and all my other colleagues. I'm going to take you through where next. So you can see we've taken you through the why, the how, and the results. So we have this immense amount of data. We've proved we can reduce postpartum hemorrhage by 60%. So what next do we want to do? So of course, we want policy and guideline change. We want eventually guidelines to come in to say that this should be the standard of care, and that has to go through its process of it emanating from the national, international level, coming to local. So that is a whole process. There is also a lot of effort by the team at Birmingham University to try and unpack, to look at what components were done well, what components were. So there's ongoing work on that. So let me come to something that's going on closer to home. Dissemination and implementation. What we are doing today is part of the dissemination. We've been disseminating and will continue till everybody knows what we did and what it means. We also have, as most of you are aware, FIGO has a project which is being implemented through the COGS office. Dr. Wamai is the lead person for that. It's called the EMPLI PPHI. And this is an intervention going on in Makweni, where they have other things in addition to what we are talking about. So that is also ongoing. I also wanted to let you know that the Gates Foundation, which is the funder of this project, had a lot of interest, and we are actually going to do some sort of a pivot in which we have activities going on in all the sites that were participating in this trial for 1 year going on from now. And we'll share a little bit. So what are the key messages that we want to share with all of you? So for the healthcare providers, we say that every second of uncontrolled bleeding risks the life of the woman. Visual estimation is blind. We need to have all the elements to be delivered by midwives. And we can do this through all the interventions that have been spoken to you about by my colleagues. Next. So for healthcare providers, we need to, for the policy makers, we need to inform them that we expect this to reduce maternal morbidity and mortality. And the investment in EMOTIVE will reduce downstream demand. And the slide is not moving, but I'm continuing to talk on the next slide. Downstream demand on health services. So if you diagnose postpartum hemorrhage early, you treat it early, you'll reduce the amount of women who get postpartum hemorrhage to an extent that you need to give blood transfusion. You're going to reduce that. You're going to reduce the care. So eventually, it's going to benefit the health services. So with regards to what are we talking about to the researchers? So the researchers need to come up with what is sustainable and affordable as an innovation around the blood loss assessment. We have these drapes, but we need to talk a lot more about these drapes. What else can we do? What we are showing you here is something that our facility in Malindi said, okay, the trial is over, the drapes are over, what do we do now? They took up some Macintosh, and through their tailoring department, they came up with a drape made from Macintosh, which they would put, and then it would trickle down. And at the bottom, as you can see, there is a basin, and they had it calibrated. And they said, okay, let's use this and then we will keep on reusing. So they had a few manufactured. So this is something that, was an innovation on their side. So we also need to move on from just the lower middle income countries to the high income. We need to look at how this can apply to cesarean section and improving effectiveness and cost effectiveness. We'll talk a little bit about it if we have time. So there's a lot that needs to go on from, the healthcare, the facility, the researchers, and of course the funders. Next, please. So I know we have quite a few questions that we would really like to answer. I know we are nearing our end time. I would just like to take a few minutes to acknowledge all of us who participated. And I would like to start by the top picture, which is Professor Ari Kumar Sami, who was the chief investigator at the University of Birmingham and the Birmingham Clinical Trials Unit. It was such a pleasure to work with him. And, we went through this extremely, extremely difficult trial, but it was so interesting to go through it. Our own team, which we've all been talking to you, recognizing Professor Guantai was our study pharmacist. And we had our data team, we had our study coordinator, our implementation midwives. And I would like to really thank all of them for being part of this trial. Next, please. We had a meeting after having been talking to each other online for a very long time, because we started this in COVID. Finally, in October 2022, we were able to meet physically, face-to-face. It was really a pleasure to see some of our colleagues. We met in Mombasa, and this was for all the champions from the 7 implementation sites. So this is just a picture. It was so wonderful to have this. And thank you, everyone who participated in this. Next slide. I would like to acknowledge the funders, Bill and Melinda Gates Foundation, WHO, University of Birmingham, our own university, the Ministry of Health and COGS, who've been, with us, knowing what we're doing, Japaigo, who was partnering with us in all the trainings, all our 19 facilities, the adaptive cycle sites, the 2 we had to drop, the 7 intervention, 7 control, all of you who gave us so much support to make sure that we did everything correctly. Our research midwives, we were employing a staff of about 100 in this trial, which was immense. Our county and hospital management teams, all our patients who participated, all the regulatory authorities. And finally, to tell you that the results of this trial were released on the 9th of May at the conference, the ICMNH conference in Cape Town. The publication came out the same day as the results were launched in Cape Town. So please do find some time to read this, a paper and the one on the drugs. And with that, we will now hand over to our moderator, and we can answer the questions that are there. And of course, we have to have a few questions, I'm sure, from the panelists to involve them. So I will hand over back to the moderator. Thank you very much for listening to us. And apologies that we've gone a little beyond time.
Thank you very much, Professor Qureshi, and the others, Dr. Soti, Dr. Guaco, Polycarp, Poyo, and everybody for listening. Very exciting and excellent presentations we have seen here. Of course, we are reminded that we are talking about a major kill of women in this, not just in this country, but globally, with almost 810 women dying per day, meaning every day, every hour, we are losing like 34 patients or women to maternal mortality, of course, PPH being a major aspect. So as much as we are running out of time, I would request that we be patient. We were supposed to end at 8:30, but I will urge that we be patient up to around 9 when we can wind it up. I would like now to welcome panelists, Professor Onyoro, Dr. Alan Nicole, and Dr. Joanne Okemo. There are several questions which have been put there. One of them is, just to start you off, is how did we deal with the confounders? the liquor, which invariably would have been part of that fluid which dripped down, the gauzes which may have been used, the swabs and the like. That is one. And then secondly, you may have answered it, but maybe some of us may have missed. How did we handle those patients who came in with a vaginal birth after cesarean section, or commonly called trial of labor after cesarean section? Over to you. Dr. Guaco, you could answer those questions and then the panelists to continue.
Thank you, Dr. Maranga. So one of the questions, yes, we get asked a lot is how we handle the amniotic fluid, and as you said, the gauzes, swabs, and urine. So for the amniotic fluid, the drape was unwrapped after delivery of the baby. For the blood, for the gauzes and swabs, yes, they were, especially the ones that were fully soaked, they were included in the blood measurement. They were included in the drape. Dr. Osoti, Prof. Qureshi, any additional comments?
No, I think what you've said is correct. So basically, we do recognize that we do not want anything other than blood here. So we, as you said, we would place the drape under the buttocks, but then after the delivery of the baby, when almost all the liquor is out, is when we would roll it out and then have. And for gauze pieces, we had instructed the facilities to use just small gauze pieces, which weigh less than about 10 grams. And they would have to be fully soaked to be put in. So it's not like you keep just dabbing a little bit with 2-3 spots and then you put it in. So those are the instructions that were given. And remember, this is a study, so we really needed to control. So that's how we dealt with the gauze and the amniotic fluid. There are quite a few questions on the drape. Maybe at some stage we can answer them collectively. If that's okay, Dr. Maranga?
That's okay. Over to panelists, Professor Onyoro, we can start off with you and then continue the call and Okemo. Professor Onyoro.
Thank you very much, Dr. Maranga, and thank you, team. I think this is great work. Reducing this composite outcome by 60% is not a small feat. And I think if we can be able to reduce PPH1 by making sure that when it occurs, we are able to recognize it, which I think this EMOTIVE trial was mainly concerned about. So are you able to recognize PPH? Are you able to assess the amount of blood loss? And are you prepared to take care of this patient by having the necessary resources available? And at the same time, are you able to respond appropriately for the PPH situation? So I think this was great, but I also look at several issues. When we look at, of course, this trial, it was looking at one of the key areas, that is when a PPH happens. But I think maybe in future, we may also want to go slightly upstream and try to look at PPH as a life cycle thing that starts from that patient when that young child gets stunted and that child has to undergo several cesarean sections, or this person gets malnourished and they go into pregnancy when they are already anemic. because we know some of the like multiple operations, cesarean sections, severe anemia are risk factors. So I think if at one point, using the emotive BADO approach and also going further to look at the system-wide and the life cycle approach in trying to reduce the burden of PPH may also gain us quite a bit of advantage. So maybe the only question that probably I may want to ask to the researchers is how replicable is this emotive BADO approach, and looking at how scalable would it be in our facilities, considering that, of course, we have problems with the resources, we have problems with the healthcare workers, the numbers are few. So of course, the getting champions and also continued motivation to be able to undertake this activity. I think this is something that we also need as we do our guidelines and change the guidelines. I think we also need to look at how sustainable is this approach and how far can we go upstream so that we don't wait for the PPH to happen. We become more proactive in more of preventing from the childhood all the way to the time the woman is pregnant. Thank you.
Thanks, Professor, for those very important points. Dr. Ecole?
Yeah, thank you very much, Dr. Maranga, the coordinator, and also to the presenters, Professor Qureshi, Dr. Guaco, Oyo, and Dr. Osoti. For PPH, we all understand that this is a matter that over the many years, it's something that has been discussed from the time I was probably in undergraduate, the things like Alma Mater Declaration in terms of women's health, to the international conference in Cairo that's 1994. All that has always been concentrating about maternal health and how to improve outcome in terms of maternal care. And you find with PPH being a leading cause of maternal mortality, I'm happy that we are putting more effort into this subject. The other thing is we all understand that we all have all these guidelines. We all have literature on PPH, and it's good that there is more literature and more of the implementation research that is coming up, like what has been done by the team, WHO, the team in Kenya, concerning the EMOTIVE, and something that is probably can be replicated locally. It's something that we normally do, is only that probably we haven't packaged it in a way that can be easily be implemented. And with what has been done, I feel that as a country, it is something that we can adopt. The issue now to do with how can the end user feel the benefit of all that has been done. And it comes to the aspect of implementation for me, whereby where do we face barriers towards implementing some of these great ideas that are being discussed? And we have to look for ways in which we can participate in terms of especially advocacy and even the politics of the land. I know doctors sometimes we really don't wish to get into politics, but we realize that most of the decisions are made at board level, whereby we need to be there to break it down to the political class that this is what PPH means. This is what it means by just implementing some of these strategies that have come up, that research has been shown, that can reduce morbidity and mortality by almost 60%. So for me, those are among the things. And the other thing is, from what we have, how can we implement it more locally, and how can we also bring about the other aspect of measuring our progress. I liked it that from the EMOTIVE, they were able to give feedback to the facilities that this is what we have been doing. These are the implementations we have been doing. These are the outcomes. These are what we are facing. Last month, we were in this position. This month, we are here. And I think it helps in motivating the staff towards more even acquisition of more skills. The other thing is just in terms of supplies, we really need to push as either doctors and also within our advocacy in terms of supplies, because you find that most of these drugs that have been used in the EMOTIVE, whereby we need tranexamic acid, we need oxytocin, and we also sometimes we need misoprostol. So we really need to find ways on advocating for how can we get all these supplies so that we don't have stockouts. The things to do also with staffing, how are we able to bridge the gap? And in terms of the biggest Achilles tendon that I feel when it comes to management of PPH is mainly early detection, especially in what I say unregulated facilities. You find we have multiple facilities from the level of a private, small private institution to the level of the National Referral Hospital. So you find the time it takes for a PPH to be detected in this small center to the time that the patient gets appropriate care, you find by the time the patient arrives in the center that is either to implement some of this, especially blood transfusion, you find the other EMOTIVE, whereby just early detection, uterine massage, oxytocin, tranexamic, maybe are not being given in the low CADA centers. So we need to escalate it downwards to the centers that are doing most deliveries, because you find especially vaginal deliveries, on how they are able to implement these great ideas that we have. In terms of also the aspect of the disparity of access of healthcare, you know, and we all know that women from low socioeconomic status bear the great burden of most of the complications of pregnancy. So especially PPH, we need to find ways of also just economic empowerment, education, and all that. But it was a great presentation, and I would really wish for the team if in terms of implementation and adopting some of the ideas I have to fit the local setup so that we are able to reduce on PPH morbidity. Thank you.
Thank you, Dr. Nicole, for those comments and for bringing up the issue of implementation, basically from research to the ground, so to speak, where the rubber meets the tarmac. And of course, the issue of supply and the issue of how we interact medicine and politics. So as I give the next chance to Dr. Joanna Okemo, maybe we could also be thinking about what's really the target of these interventions, especially as was carried out. Because if you look at the facilities which were used were mostly in the counties and the like, and the public for that matter. Of course, in tandem with that is what Dr. Wende has asked there about could that collection gadget, so to speak, could it be a bit softer? Could it be a bit warmer? Because lying on a cold plastic after delivery can be quite uncomfortable. But then, of course, you're dealing about PPH, where maybe comfort may not be one of the priorities, but I leave it for you to ponder and maybe answer on that. Dr. Joanna Okemo.
Thank you so much, the moderator, for inviting me, and thank you for the opportunity to be here today. A big congratulations to the researchers who did this project. It is really, really commendable work. And I'm such a proud Kenyan today and obstetrician to just see that part of us took such a key role in this research. Some of my take-home messages from this paper is most of it has already been shared and most of it has already been mentioned by the previous speakers and panelists. But I think I'll still reiterate some points. One of them is preparation is key. I think from what we have seen from the EMOTIVE trial is that having established protocols and guidelines go a long way in preventing or managing PPH. And I know most of our facilities don't have protocols in place or guidelines in place. And whenever you're faced with an emergency, it's very hard sometimes to just remember things off your head and act, especially given the adrenaline and the fact that you're dealing with a life that can potentially be lost in your hands. And therefore, just having established guidelines that people can refer to and read and, so that it's as easy as ABC, I think is very important. And EMOTIVE trial has given us such an easy way of even just trying to start with the first bundles of care in managing PPH as well. Training and simulation, of course, cannot be overemphasized. I would say that the more, even as we establish protocols and guidelines, we need to train not just doctors, but also nurses, midwives who are involved in the care of our patients, because most of the time they're actually the first responders or the people who are handling the deliveries and or junior doctors for that matter. And everyone just needs to be very well trained to have drills over and over until all this information and steps of management is like inculcated in our brains completely. I would also say that some of the times that we drop the ball is actually the postpartum ward. We tend to be a bit more careful during the delivery process, but the ball is dropped when the patients go in the postpartum ward for recuperation. And I was just wondering whether these calibrated drapes, or we can have an objective way of actually monitoring for the loculus, even for women who have just moved from the delivery unit to the postpartum ward to recover. Because we have had instances where women have actually collapsed in the postpartum ward because no one was really paying attention to the amount of blood that they were losing, or even the vital signs, the changes that was happening to them. So just a food for thought on how we can also extend this to the postpartum ward as much as we do it in the delivery unit as well. Prediction and prevention, I think, is also quite key. When you are faced with a PPH patient and you are already doing the EMOTIVE steps, you are stuck with the patient most of the times. And at that time, I think the life of that patient really depends on you as the clinician to do the best that you can. And if you didn't have enough in terms of preparation, sometimes you may actually lose the patient. I just think that in terms of also educating ourselves on the ways of prediction and prevention of PPH, especially in proper identifications of patients who are at risk, trying to manage antepartum anemia so that the blood levels are well, trying to identify patients who, for example, are at risk of getting placenta crater spectrum, and just trying to make sure that the patients that you feel cannot be managed in your unit, you have proper referral systems in place and have proper timing for delivery done. It will be very unfortunate, for example, if you had a patient who comes into the unit at night with placenta previa and they're there and you're stuck with them and you are not prepared for that at all. So I feel like just assessing your patients well and training people also in the prediction and prevention of PPH and knowing when to time your deliveries well in a way that is well controlled and organized, where you have competent teams in place, or referring them to places where things can actually be done to save patients' lives, can also go a long way. But that's all I'll say for today. A lot has already been said. Kudos to the team, and I hope we learn a thing or two from this and implement it. Thank you so much.
Thank you very much, Dr. Kemo, for stressing the issues about training, and training, of course, especially of the first responders, the midwives, the medical officers, the clinic officers, and of course, having drills. That's very, very important. And of course, as Professor Qureshi mentioned, the issue of developing protocols and implementing them as such. And of course, we all know that post-delivery care, that is when not really most, but a number of major complications and even mortalities occur. A patient has had delivery, whether with postpartum hemorrhage or otherwise, and then after that goes or is put to sleep or is given a bed to rest, and observation doesn't occur, especially when it's at night. And even in some of the major hospitals in Nairobi, I don't want to, for fear of prosecution, I'm not going to mention any. We have had such in all facilities whereby a mother is lost and is discovered in the small hours of the morning to have actually bled and gotten exsanguinated to death. So post-delivery care, extremely, extremely important. Back to Professor Qureshi and team to address some of those burning questions there. I hope in the next 10 minutes at 9 sharp, we should be able to wind it up. Professor Qureshi and company, please.
Let me start. Thank you very much. So I think there have been a lot of questions with regards to implementation. So I would like to just very quickly take you through some of those. Remember, we mentioned that Pakistan was supposed to be this trial, but for some reason it couldn't. So right now there is a trial that will happen in Pakistan on implementation research. So what we were doing as a trial in research settings will now happen in Pakistan, but as an implementation research. So we'll see in real life circumstances how this is, going to take place. So that's a very important part. The Bill and Melinda Gates Foundation was so excited by the results that we got. So they have supplied drapes to all the 4 countries for all the facilities that participated in the trial for 1 whole year. So that is something extremely important and exciting for us. And the facilities are really, really excited about this because, they've said that when you have a drape and you put it under the patient's buttocks, then the whole environment is really clean. Every blood, all the blood goes in and there isn't any spilling. So even the cleanliness gets affected. So that is happening. So right now what we are doing is that all the facilities that were the control sites are now going through trainings. We had a training in Gatundu last week, which was a control site. So they will now be taught about what it takes to do the EMOTIVE bundle. They have been supplied with trolleys, carry cases, and everything else that's needed, the blood pressure apparatuses. Of course, we are not employing staff, but we are training the staff to do this. So they will be all coming on board soon with trainings, and they'll take it up themselves. And then the intervention sites are also going to go through, keeping up with what they were doing. So we are going to encourage the facilities to do everything that we were doing during the study. And a lot of you have asked questions beyond the study, how will we make sure that all this is maintained and done? That is what we are waiting to see. Understandably, there are a lot of shortages in facilities, even essential commodities are missing. Sometimes you have misoprostol missing, oxytocin missing. The brands that we've talked about, tranexamic acid and oxytocin, that we know are poor quality, are still there. But the facilities tell us, look, when we order, it comes from KEMSA, we have no control over which of the brands we get. So that is something we still need to deal with, and we'll continue working on that. So for drapes, right now we have 1 year supply for those 19 facilities. But beyond that, there's a lot to be done. Remember, these are plastic drapes, they are incinerated, they are going to create a lot of issues with environment. So a lot of work is being done on biodegradable drapes, drapes that the lower part can be removed, and the bottom one, the top one, reusable. So a lot of work is ongoing into other forms of drapes, looking at all this. We already have some new prototypes. I think they've been sent to Ruiru. We will have some of the biodegradable drapes come in and sent to Kakamega. So all our facilities will participate in something beyond what the trial was. Audit and feedback, we are encouraging them to, keep up, but let's see how much of it will be possible within the working conditions of the facility and what will not be. So we are in this 1 year further exciting period. That is where we will come in. Our ministries, our associations will say, okay, look, this is the basic minimum. Postpartum hemorrhage, if we detect it early with a drape or something that will tell us this is PPH, then we have everything else reduced. So how are we going to get drapes? Right now, we were procuring them through the project. A lot of you had been asking us through. We're also looking at some local manufacturer. We're going to investigate more into that. And if it's manufactured locally, it's also going to be very cheap. So those are all the things I wanted to say. Maybe it's only 5 more minutes left with Dr. Osoti and Gwako. Would like to add on to anything else that was in the chat box, please go ahead. And from me, thank you very much.
Thank you, Professor Qureshi and team, and Dr. Maranga for the great moderation. I just want to add that what we currently practice is sequential, where, if a patient has PPH, then you massage the uterus, then observe. If it doesn't work, you do something else. You give more oxytocin, you give tranexamic acid. Sometimes even forget to give tranexamic acid. So what we are saying is we need a bundle approach within that 15-minute period. So you don't massage the uterus for 10 or 15 minutes and then come back and, try one intervention after the other. So we are, emphasizing the bundle approach, which I think we can do in most of our facilities right now. The only challenge that we have is with the drapes, and Professor Qureshi has mentioned what is being done about that. But this is a great opportunity for local manufacturers, local scientists, local researchers to try to be innovative and try and see whether we can develop something that can help us achieve this. I think we have great people within our team that can be able to, within this country, that can be able to do this. So we can put our heads together and see whether we can develop something that can help us to measure the blood loss. But in terms of the bundle, I think most of the facilities we work in have all this. So there should be no reason why we should not implement the bundle. So we will go ahead and train, disseminate this, and also train facilities as we, get support to do that and be able to roll this out. Somebody had asked whether this is available in private hospitals. Of course not, because we have not secured, enough drapes and sources of that that can reach the whole country. But in terms of the other components of the bundle, they're actually there. So I think we can do a great job as we try to figure out the issue of the drapes. Dr. Gwako?
Thank you, Dr. Sot. I also want to join you and Professor Qureshi and the other panelists to thank everybody for attending, for the questions and the comments, Maranga for moderating this. Most of the questions and concerns have been answered. My parting shot is that BPH causes quite a number of maternal mortalities. There's no doubt about this. And a lot is known in terms of diagnosis and management. So probably the bundled approach, as we sort out the issue of early detection, might be the magic bullet that can lower our maternal mortality in Kenya and all over the world. So in our own rights, let's try to move our practice, as I sort of said, from the sequential management to the bundled approach, and maybe we might lower our maternal mortality ratio from the 300 to the 1 or 2 digits that we as a country have always anticipated to have. Over to you, Dr. Maranga.
Thank you very much, Dr. Gwako and the others. So as we come to the close of this engaging evening presentation, let's remember and think EMOTIVE. For me, that's the take-home message, and I hope for all of us who practice deliveries, either as a midwife or as a medical officer or as a clinic officer or as an obstetrician, let's all be thinking EMOTIVE, and especially the E's, early detection, and the last E, which is escalation. There are a number of times when most of the time bad outcomes do occur because of those E's. Early detection, we miss it out, and then we don't escalate. Let's always know that even as a consultant, obstetrician, escalation would always help. It's always good to have a second eye to assist. If you're a midwife, kindly escalate. Everybody needs to notice that when it reaches a certain point, then certain things must be escalated. So would wish to thank our speakers, Professor Qureshi, Dr. Soti, Dr. Guako, Polycarp Oyo, our panelists, Professor Wanyoro, Alan Nicole, and Joan Okemo. And I wish to wish all of you an emotive night, emotive day tomorrow, an emotive year, and an emotive obstetric career or midwifery career. Have an emotive night. Good night.
Thank you very much.
Thank you. Thank you very much.
Thank you.
Thank you so much.
Bye. Bye.